The Conversations on Health Equity Online video series is produced by the Health Policy Research Consortium, funded by the National Institute of Minority Health and Health Disparities. Located in Greenbelt, Maryland, under the leadership of our principal investigator, Kwesi Nfume, HPRC conducts policy research on issues related to health inequities throughout the country with a focus on the Mid-Atlantic region. HPRC uses a transdisciplinary research approach to close the gap between policy and science by assessing how current and proposed policies affect various populations. Major research efforts underway include the Health Policy Literacy Study, the Policy Portal, various research papers focusing on behavioral and social sciences, and a cardiovascular disease study focusing on disadvantage in the food, built, and social environment. For more information, visit our website or our social media channels.
Now, there's a word you mentioned, and I want to stay there for just a moment, justice. And I know social justice is an important framework that's now being looked at as an intervention for health disparities. Thomas Levis, Paula Braveman, and Nancy Krieger, a number of other leaders, health equity leaders, including yourself, are talking about the need to look at social justice. At NACCHO, the Health Equity Program is in fact looking at social justice as a strategy for addressing health equities. Help us to think about what that looks like, and especially in terms of, are there policy interventions, or is there something that you can do programmatically with social justice that makes the wheels turn and reduces health disparities?
Well, let's first say that social justice is not simply, a piece of rhetoric. It has a long, long history that goes back probably thousands of years, but the modern idea of social justice and that terminology begins during the Industrial Revolution. And basically, it has at least two parts, if not more. One is social and economic equality, and the other is political equality or democracy. Without those things, it's very, very difficult for people to be able to take control of their lives in their everyday lives and the things that will affect them, and to express their full capacities as human beings, as groups of people in a society. And in terms of our work on this phenomenon, we are trying to determine how do we transform structures of power through democratization that can influence the nature of policy, because before policy, you have a set of rules, and you have to do something about that set of rules before you're going to enact the policy. For example, the United States was begun a number of hundreds of years ago. It was a structure of inequality of vast proportions. It was built on slavery, women were chattel, and only propertied white men could vote. You could build all the rights you wanted to into a Bill of Rights, but you have a structure of inequality. And there's no program, food stamps or whatever, or social welfare that's going to resolve that inequality in the structure of power. We have to think the same way today in terms of what is it that is continually generating these inequalities over and over again. Why? How does it work? I think right now we're seeing an economy that's based upon people being disposable, essentially. Everything is for investors, economic growth endlessly. There's never a saturation point where it stops. People are being more and more displaced. People don't seem to keep jobs more than a few years. It's insecure. It's a disruption of social life, and it's worse for some populations more than others.
I want to ask you a question about how do we transform how we think about these kinds of issues? Because this is really a radically, fundamentally different way of thinking about health inequity. Once again, it moves from programs and services approach to looking at structural and systemic issues. So I'm wondering, how do we get folks to change how they think about these things? Public health sector, policymakers, and certainly the general public. What do we do with that?
Okay, well, first of all, I think it doesn't have to do so much with trying to persuade people, because they don't generally respond to facts very well, as we've seen in many cases. I think it's through insight and discovery. And so, for example, the Alameda County Health Department, 5 years ago or so, they did a major study on the impact of foreclosure on health.
That's in California.
In California, right, and in Oakland. And most people would not, in public health, don't think of doing things like that, that's a bigger issue. And that had a tremendous impact, I think, on a lot of people in realizing that banking policy, has an impact, and they have to do something, and they have to take some action. And they did this research. It wasn't some hidden away research in academia. This was working with a local organizer group, Justa Causa, I believe they were called. And they did this in complete cooperation and collaboration with that group. And part of that process itself of doing the research was an organizing effort. And they got a lot of people involved, a lot of people paying attention, a lot of press to it. And people began to see, these kinds of decisions and land use decisions and zoning decisions and all these things are affecting health. And there's something that can be then done about it. And the health department began to do actions around those kinds of issues and helping their constituents. Another example, I think, is a work that we've been doing for a number of years with a series of groups in the Midwest and a project called Building Networks for Health Equity that involved 5 or 6 states to begin to align public health departments and local community organizers, mostly faith-based, and not simply to form a coalition on an issue, but to develop a permanent set of alliances that would run through a whole series of phenomena that related to both racial and health equity, and work together on these, and then come together as groups from all of the different states to strategize. One of the main things they worked on that had implications beyond the subject matter was mass incarceration, which itself is an attempt to weaken the political power of African Americans through denying them the vote when they leave prison, and taking them out of the population and disorganizing their social lives and stressing them out. It's a public health crisis. And these organizers were able to work on this phenomenon in that way with the knowledge that they have about how to mobilize a constituency, and with the kinds of authority that the public health departments have in defining what this is about. That's another example of something that can be done. Finding allies, committed, powerful allies who can work with you. You can't do this by yourself. The state health department in Minnesota did a major study of living wage and its effect on health, and it influenced the state legislature, which enacted a $2 an increase in the minimum wage. Local health department in California at one point had done a study of living wage, and it influenced the city council to make changes in that regard.
And these are all the social determinants of health.
Yes, when you look at them that way one at a time, but they're basically, if you build on them, and you recognize that it's the same set of institutions that are generating the phenomena, the problems, then you can begin to see a pathway forward. Health departments themselves, we're trying to encourage them to gather different kinds of information than they are used to locally. So they are very familiar with building maps, these GIS maps of health outcomes, and overlay with poverty, overlay with other conditions. We are hoping that they can identify, without spending a lot of money, but locally identify, and non-scientifically possibly, information about gentrification in their communities. Who's getting redlined? Where are developers placing various kinds of projects in these areas? What is the allocation of the city budget by neighborhood? Why do some neighborhoods have a higher life expectancy and a great deal of negative conditions? So there's a number of things that can be done at this broader level than simply treatment by service, which is necessary, but not enough.
Now, it seems to me that in the health equity program, you have a number of efforts that are underway where you're trying to educate the public health sector and the general public on how to address these kinds of root causation issues. I think there's a webinar that you have. There's also a handbook, I believe, that Health Equity the Health Equity Program is doing.
Right.
Do you want to talk about that just a
Yes.
bit, those specific
Sure.
efforts?
Yeah, we have a course that was originally funded by the National Institutes of Health called Roots of Health and Equity. You can find it at www.rootsofhealthandequity.org. And it's not a traditional course, it's an interactive course that's like a museum. You don't have to go from beginning to end. You can pick and choose what you need. But the goal of it is to provide people with insight rather than lots of facts. There are facts in there, but the goal is to be able to see differently, to observe differently, and to then change the strategies in which you think about these inequities differently.
And as we wind up, how does the handbook fit into that effort as well?
The handbook is really dealing with how public health staff and departments overall can transform the narratives in which we think about public health. For example, we tend to have language that's problematic. So sometimes we talk about vulnerable populations. People are made vulnerable. We use phrases like, you might write a sentence that says, low-income people have the highest level of coronary artery disease. I would say people who are underpaid and forced into poverty have the highest level. Or Native Americans have the highest level of mortality. I would say Native Americans dispossessed of their land and culture have the highest level of mortality in the U.S.
So it's all about, as you said, transforming the narrative. And it seems to me that a great deal of the work that you're doing at Health Equity Program is trying to do that, as well as Health and Social Justice, the book that you edited,
Right.
seems to be providing an academic framework for changing the conversation, for
Right.
transforming the narrative. Dr. Hofrichter, I just want to thank you again for the insights that you provided and for the decades of commitment that you've made to addressing health and social equity. Thank you for joining us on Conversations on Health Equity. Learn more about future episodes by visiting us at www.hprc.info.